Assalamu alaikum. I'm back again after lunch. So in this second talk, I'll be focusing on new targets and drugs in MDS. And I thought to separate them into lower risk MDS, higher risk MDS, and things that are going to be applicable hopefully by next year versus things that are earlier in research. So when we think of lower risk MDS, which still is the majority, like 58% of the cases, most MDS patients actually that are lower risk don't progress. So 70% of the MDS patients that are lower risk will stay in the state of lower risk. However, unfortunately, more than half of them will still die from the disease. So, and I think in our area, lower risk MDS is really unrepresented or underrepresented. The patients present with anemias, they go years not diagnosed, and they only are diagnosed if they are a higher risk disease. However, when we look in our database, once patients with lower risk MDS become transfusion dependent, their median survival is around 3 to 4 years. So even a lower risk MDS is the disease that impacts patient survival in addition to their quality of life. Obviously, anemia and red blood cell transfusion dependency are the hallmark of the disease. And study after study had shown that patients that are transfusion dependent have worse outcome, and it does correlate with worse outcome and survival for those patients. And recently, through several studies, we've shown that transfusion independency is associated with better overall survival. This had been shown through lenalidomide studies in deletion 5q, recently with luspatercept, and from real-world data. And when we think of lower risk MDS, we really should separate those into the disease biology based on even the new classification I showed earlier. So we think of deletion 5q as separate entity, MDS with SF3B1 as separate entity, and we should not be lumping them together because even the mechanism of ineffective erythropoiesis is different among those groups. So when we think of treatment, most of the time we are thinking either targeting the clone. Our hope is obviously to eliminate the MDS clone and restore hematopoiesis, or differentiate the clone. But there is also a lot of interest recently in targeting the inflammation, which is a very important component. And it's almost like the egg and the chicken, which started first, the inflammation that leads to clonal instability, or it's the clonal events that leads to inflammation. It's hard to answer, but there is no doubt that the inflammation is important to target as well. So one of the recent studies that may change how we apply things is this CentraRev study conducted by the Spanish group. This was really an elegant study in patients with deletion 5q. Originally, the approval of lenalidomide, which is the standard of care in deletion 5q, is for patients that are transfusion dependent. So the Spanish group randomized patients, took patients that are anemic but not transfusion dependent. So once they have mild anemia, to a 5 milligram, which is half of the dose, for only 2 years, so it's not indefinitive treatment, and compared that to observation. And indeed, what they showed that the time to transfusion dependency was almost around 66 months with this approach versus less than a year without, on observation. They also showed that the cytogenetic responses were higher, almost 80%. And they also looked at the clonal evolution, and they showed that many of those patients stayed stable. Even among subset of patients that had P53 mutation, they showed that the clone remained stable. So this, I think, will change our way of practice in deletion 5q, that we could think of introducing the treatment earlier for those patients, only a couple of years treatment, and then observe those patients. Now, luspatercept, as you well know also, is a fusion trap protein that neutralizes TGF-beta ligands in the serum, releasing the terminal erythroid differentiation block. Luspatercept is approved for patients with MDS ring sideroblasts that are transfusion dependent. So what we tried to do is to move the luspatercept up front. So this is the first effort to compare anything to erythropoietin stimulating agents in lower risk MDS. So this command study was just recently published in Lancet. It was presented at ASCO, EHA, and it will be re-presented again at ASH. It took patients that were lower risk, transfusion dependent, but not high transfusion burden, randomized them between luspatercept and erythropoietin. And indeed, the study met the primary endpoint, doubling the erythroid response or the transfusion independency, almost 60% versus 30%, and more durable responses. But when you really look into the subset analysis of this, There was only a handful of patients, almost 49 and 48 on each arm, that were RS negative or SF3B1 wild type. And in that group, like, there is no clear superiority. The responses were the same. So I think we are moving forward with luspatercept maybe as frontline in patients with ring sideroblast. However, in the patients that are ring sideroblast negative or SF3B1 negative, I think it's not cost effective yet to move this treatment up front compared to ASA. This is the transfusion dependency all over, but it's really the magnitude of this is more seen in patients with ring sideroblasts. Now, our group had been interested in combining erythroid-stimulating agents with luspatercept, and there are 2 ongoing studies with that. This is a case series that we published that we actually saw responses in patients after luspa failure if we did a combination with erythroid-stimulating agents. It turned out that patients that had endogenous serum EPO less than 500, SF3B1 mutation, or what we call a secondary luspatercept failure were more likely to respond. But with the combination approach, we were able to restore responses in almost 30% of the patients. Similar to luspatercept, there is another drug in development, KAR050, and there will be opportunities to join this study, phase 3 of it. This is an activin 2A receptor. It's similar to luspatercept, but more close to sotatercept, a drug that we tested in the past. It has more trilineage activity, so there is platelet and neutrophil response. And in the phase 1 study, at least, there is promising activity that it performed well in patients that were highly transfusion dependent, where luspatercept responses are actually less, and also in patients that are ring sideroblast negative. So we are planning a phase 3 trial with this compound as well. Now, the other drug to mention is Imetelstat. Again, the data were presented at EHA and ASCO, and we will be presenting the data to the ODAC in April hopefully for approval of the drug. So Imetelstat is telomerase inhibitor. It's been tested in both MDS and myelofibrosis. In the phase 2 trial showed promising transfusion independency response. So the EMERGE study was a phase 3 trial. Took patients with lower risk MDS, transfusion dependent, randomized between Imetelstat, which is an infusion once a month, versus placebo. And the primary endpoint was transfusion independency again. And indeed, the study showed, that luspatercept led at least to 30% almost transfusion independency, that's 24-week or more durable, compared only to 3%. And the duration of transfusion independency is almost a year. And the magnitude of hemoglobin increase was around 3.6 grams increase in the hemoglobin. So this is second to lenalidomide in deletion 5q in terms of the magnitude of hemoglobin increase. And what's unique about it, that it was active in patients regardless of the baseline transfusion burden, and also in patients that are RS negative, which again distinguishes this from luspatercept that tends to be more active in patients with ring sideroblast and in patients that have low transfusion burden. Now, the major toxicity with Imetelstat is myelosuppression. So there is grade 3 and 4 thrombocytopenia and neutropenia, typically observed in the first round, that leads to delay in cycle 2 and dose reductions. However, the rate of febrile neutropenia was less than 1%. And what's interesting that we see also potential disease modification with Imetelstat. There were changes in the bone marrow ring sideroblast, cytogenetic responses, and almost in 1/3 of the patients, reduction in the allele burden of mutations such as SF3B1, but others including DNT3A, TET2, and SXL1. So this is how I think we will be managing MDS, hopefully early in 2024. So once patients are having symptomatic anemia, I think we'll be thinking of treatment. In deletion 5q, there is room of using shorter and lower dose of lenalidomide, 5 milligrams for 2 years. In patients with ring sideroblasts, I think luspatercept will become first line, Imetelstat will become second line. In patients that are non-del 5q, non-ring sideroblast, I think there is still, studies needed to show that luspatercept is really superior in all the cases compared to ESA. But in subset of patients, particularly if their endogenous serum EPO level is high, we can use luspatercept. And Imetelstat could be an option for patients as second line if they only have anemia, platelet above 75, and ANC above 1,000. We still use low doses or short courses of hypomethylating agents in a lower risk, particularly if they have concomitant thrombocytopenia and neutropenia. Now, some of the evolving, studies in lower risk are looking at targeted therapies. For example, this is, our data looking that IDH mutations are enriched in patients with neutropenia. So if you encounter, neutropenia is more common to be seen in higher risk MDS, but rarely can be encountered in lower risk MDS patients. And we only treat if patients have recurrent infection. You really don't need to treat for a number of neutropenia in lower risk MDS. Those patients do well in general. But if patients have recurrent infection, responses to hypomethylating agents are less than 20%. So we are always in need for new therapies for those patients. And our data suggests that this population is enriched with IDH mutation. And we've treated small series, and now the numbers are a little bit more than this, that it seems that they will elicit a good response to IDH inhibitors that are usually sustained. Also, people have been looking at spliceosome inhibitors. Several years ago at ASH, there was a plenary session showing that if we further inhibit spliceosomes in patients that have splicing mutations, that leads to almost of the principle of synthetic lethality in the cells. This compound H3 Bio 8800 was tested in MDS across all cohorts, but later on they focused on a small group that had lower risk MDS that had certain ratio of this gene called TMEM14C, and now the studies are moving forward to look at those spliceosome inhibitors among those patients that have this certain gene expression. Our group had been interested also in an antibody approach. So this is a drug JSP191. This is a monoclonal antibody against CD117 with the idea of depleting both healthy and MDS stem cells with the hope of recovery of the healthy stem cells. It's also being tested as part of conditioning for allogeneic stem cell transplant. So we just started this phase 1 study in patients with lower risk MDS. So this is an antibody approach approaching the stem cell clone in MDS. Now, there is a lot of interest, obviously, exploring inflammation and targeting inflammation. We've conducted several studies in the past with anti-inflammatory agents in MDS. Most of them were later in the disease course, where I think once the disease is very clonal, the role of inflammation is less. So now we are moving those to earlier stages. So one of the approaches is obviously targeting interleukin-1b. This is very crucial in the NF-kappa B pathway activation and in a phenomena called pyroptosis, which is one of the mechanisms of cell death in MDS in addition to the apoptosis. Canakinumab is an anti-interleukin-1, and indeed our colleagues from MD Anderson had conducted the first study looking at lower risk MDS patients. They saw modest activity, only few patients responded, but when they looked at the molecular profile for those patients, it were patients with TET2 or DNMT3A mutation that had the response. So now the studies are more geared to focus on those epigenetic mutations. We are testing this in combination with ESA, and there is a national study trying to look at canakinumab in patients with CCUS as a precursor state for MDS to test, if this, approach will prevent the progression of the disease to frank MDS. Similarly, the inflammasome is the other pathway other than the toll-like receptor that's activated in MDS that leads also to pyroptosis and increase in the interleukin-1b. This NLRP3 compound is crucial in activation of the inflammasome, and now there are targeted therapies. DFV890 is a drug from Novartis that's a potent inhibitor for the NLRP3 compound. And it had been shown preclinically that it will restore or enhance erythropoiesis under inflammatory conditions. And indeed, this compound is a very potent inhibitor of the NLRP3, and we just opened this study looking at a phase 1 study with this compound in patients with lower risk MDS. There will be 2 cohorts for dose optimization, one in MDS and then also in CMML, looking at 2 doses, and then moving to expansion in the same 2 groups of lower risk MDS and CMML as well. Another approach is also approaching IRAK1, IRAK4. We'll talk about more IRAK4 in higher risk MDS. Again, this is also a downstream from the toll receptors, very crucial in inflammation. And this is a compound by a company called Rigel, and it started a phase 1 in lower risk MDS. Again, so several drugs targeting different pathways of the inflammation that contributes to the cytopenia in MDS. I think the key really is to move those drugs earlier on rather than waiting to use them, for example, after hypomethylating agents failure. Now, shifting gear a little bit to the higher risk MDS, as you well know, allogeneic stem cell transplant remains the only curative option. Hypomethylating agents are our current standard of care. Complete responses around 20%, and a median overall survival in real life around a year and a half. The original data with azacitidine demonstrated 24-month survival that nobody had been really able to replicate in real life. Now we have oral formulation of the hypomethylating agents. So decitabine, cedaziridine is a combination that allows hypomethylating agents to be administered orally. It's 100% bioavailable to decitabine IV, so it can be used interchangeably. There is azacitidine oral that's approved for maintenance in AML. That's not biologically equivalent to the subcutaneous or IV azacitidine, so it cannot be used interchangeably. There is another compound from Aztec's oral azacitidine with cedaziridine being developed as well. So hopefully as we move down the road, we will be offering our patients total oral therapy in higher risk MDS. Now, higher risk MDS has been called the boulevard of broken dreams. So there had been several phase 3 randomized clinical trials trying to improve on the backbone of hypomethylating agents that unfortunately did not show a survival advantage. So we recently heard about Imetelstat. We tested a compound called APR246 in patients with TP53, magrolimab, sabatolimab. All were promising drugs that we tested in large phase 3 and did not show a survival advantage. And I think the key lessons from phase 3 trial is that first, we should really not allow patients with P53 to be included in those studies. Biallelic P53 patients should be treated alone, enrolled in clinical trials alone, and a clinical trial should be the standard of care for those patients. And I think to improve the survival, it's an equation of higher CR rates and a durable response rate. None of those studies that did not show a survival advantage had showed a higher response rate than azacitidine in phase 3. In all of them in phase 1, 2, we showed almost doubling of the complete response, but when they were tested in a phase 3, the response rates to azacitidine versus azacitidine plus the combinations were same. And we tend to be very ambitious, so all those studies are underpowered to detect small differences, and I think we should be considerate for that in the future studies. However, there is still hope. There are 2 clinical trials that hopefully will get the read on them in the beginning of next year. This is the Verona study, which is a phase 3 aza-ven compared to azacitidine, obviously borrowing from the literature in AML, where azacitidine venetoclax had become the standard of care. So this is taking higher risk MDS patients, less than 20% blast, excluding therapy-related MDS, randomizing patients between aza-ven versus azacitidine. And important to note that the dosing of venetoclax in patients with MDS is only 2 weeks from the phase 1, phase 2. More than that was really associated with higher toxicity. Those were the results from the phase 1, phase 2, or phase 1B that led to this phase 3 trial. Again, as I mentioned early on, it was recognized that you cannot deliver the 28-day schedule like in AML. So all what's needed is 2 weeks. And many people think that we probably could get by only with a week of venetoclax. It shows doubling of the responses. Again, still underperforms in patients with P53, particularly in terms of survival. However, when we look at the whole cohort, the median overall survival looks promising, 28 months, again, compared to typically 18 months, what we expect with azacitidine. So all of this obviously had led to the phase 3 that we are hoping to get the read on it by beginning of next year. Our group had looked at our real-world data with this, so we compared almost more than 1,000 patients treated with HMA alone at Moffitt compared to 35 patients, and indeed we see doubling of the response rate. And what was really interesting for us is looking at the cohort, although very small, that went to transplant. So aza-ven as a bridge to allogeneic stem cell transplant, our 2-year survival is approaching 90% compared to 50% historical. So it seems aza-venetoclax could be a very good bridge, particularly when we are taking patients to transplant. The other group of patients where we see really benefit are the ASXL1 mutant. Those patients have less than 10% complete response to azacitidine alone. There had been preclinical data published by Dr. Verma from Albert Einstein group showing that ASXL1 resistant is BCL2 mediated, so downregulation of BCL2 could overcome that, and indeed that's what we observed clinically, where we see almost more than 40% complete response compared to historical 8%. The group also at MD Anderson had been pioneering this study with total oral therapy using oral decitabine plus venetoclax, again presenting very promising early results with almost 36% CR rate, showing again similar to what we've shown that among patients particularly with ASXL1 mutation that the combination could overcome that, and showing this promising almost 70 or 80% 1 year survival when patients go to allogeneic stem cell transplant. The group also from Albert Einstein had been looking at this principle of metronomic use. So this is a very, very low dose of decitabine, 0.2 milligram per kilogram. So this is probably 1/3 of the dose we give IV, but this is given weekly continuously. So the patient will get a venetoclax on day 1, a very low dose of decitabine on day 2, but is given on regular doses with this metronomic principle of exposure to the drug. This is a slide courtesy by the group on their early results they presented or published on the case series that they did, but this is from the trial showing that the CR rates are more than 50% and the treatment is more tolerable. So in real practice nowadays, we use this in patients that we think that they are frail, they cannot tolerate the classical, induction of the aza-ven. We use this metronomic weekly dosing of low-dose decitabine and low-dose venetoclax. Tamibarotene is the other drug in phase 3. This is a RAR alpha agonist. RAR alpha tends to be overexpressed almost in 20 to 30% of MDS patients. So this trial is a targeted therapy for patients that have overexpression of RAR alpha. Again, as I mentioned, in around 20 to 30%, and it's randomizing patients between azacitidine versus azacitidine tamibarotene. It's still earlier on. We'll probably not get a read on this study before 2025. So how do I treat high-risk MDS currently? Obviously, the first question, are patients candidate for allogeneic stem cell transplant? And we tend to be aggressive that age per se is really not limitation. Functional status and comorbidities is really what dictate if patients are eligible for transplant. If patients are to be considered for transplant, most of the time our approach is hypomethylating agents plus venetoclax. Your choice of hypomethylating agents, azacitidine, decitabine, or oral decitabine, I think are all acceptable. We take patients to transplant, and although the role of maintenance post-transplant had not been demonstrated in a phase 3 trial, we strongly believe that there is role in high-risk patients. So in patients that have P53, 11q23, or Inversion 3, we do consider maintenance with hypomethylating agents at least for a year or 2 after transplant. If patients are not candidates for allogeneic stem cell transplant and they have P53 mutation, there is really no survival advantage of adding venetoclax. So we start with hypomethylating agents. Some prefer oral decitabine, suggesting that there are higher responses, but I think all of them are reasonable option. If patients don't have P53 and they have high blast approaching the AML percentages or SXL mutation, that's where we do the combination of hypomethylating agents plus venetoclax. Again, all of this will be probably changed once we hear the data from the Verona if it confirms the survival advantage in higher risk MDS patients. Obviously, what to do for HMA failure, that's a very unmet need group of patients. The first step is really re-evaluating the disease and rechecking the molecular profile. Detecting a single mutation is probably seen in almost 5 to 10%, but collectively you'll have almost 30% of the patients with a target that you can go after. As you well know, outcomes after HMA failure are poor, with a median survival of 4 to 6 months. Those patients don't even tend to do well with intensive chemotherapy. So in cases where we identify, for example, an IDH mutation, we have targeted therapy. Small percentage will have FLT3, NPM1 that benefit from high-dose cytarabine therapy. Ivosidenib hopefully will be approved by December for patients with HMA failure, MDS, not even progressed to AML. Our group also looked at the add-back strategy. So usually what we do, we change the hypomethylating agents. So if patients were on azacitidine, we change to decitabine, and we add venetoclax. And we were able to see somewhere around 13% complete responses. Interestingly, the median survival for those patients looked even better than the upfront therapy, but part of that is bias that those patients were treated successfully with azacitidine for a while, and we added back venetoclax. This will be a reasonable regimen to consider, particularly if we are going to go for transplant in patients after HMA failure that deferred transplant upfront. The French group had been conducting studies with both IDH1, IDH2 in the IDEAM and IDEAL study. They have several cohorts. The A and B are looking at either HMA failure or upfront in higher risk MDS. And again, it had been showing promising activity. So we will have, hopefully by the end of the year, IDH1 inhibitors approved for HMA failure, and there are ongoing studies looking at HMA plus an IDH inhibitor, similar to the data with the AGILE study in AML as well. A couple of drugs that are earlier on in HMA failure are the IRAK4. This is emavusertib, which is an IRAK4 inhibitor. And from the phase 1, phase 2, from the phase 1 at least data, it seems the most promising activity are either in patients that acquire the FLT3 in AML or in patients with spliceosome mutation. So this is where the study is moving further now, enriching patients with either spliceosome mutations or FLT3 inhibition. Our group had been looking at a compound called SX682. This is CXCR1 and 2 inhibitor, which is a receptor that mediate ligand interaction between the stroma and the MDS stem cells. And the phase 1, we showed around 30% activity. Again, seems to be more in patients with splicing mutations. So we continue to accrue on this protocol. So in summary, I think understanding the underlying disease biology is key for developing new treatments in MDS. Strategies of novel therapies include targeting the clone by eradication or differentiation, targeting the inflammatory milieu or immune deregulation in MDS, especially early in the disease. The landscape for managing lower risk MDS is changing. We have luspatercept moving up front, at least in patients with ring sideroblast. Hopefully next year we'll have imetelstat for patients with anemia. And treatment of higher risk MDS remains an unmet need beyond hypomethylating agents. Thank you very much for listening again.